And usually they grow, if they grow, at about a millimeter a year. So usually it's relatively slow and predictable. And she chose to wait.
Okay.
So intelligent woman, she knows what's going on. She chose to wait. Comes back this year, a year later, and with profound hearing loss and some balance changes. And the tumor went from 7 to 17 millimeters.
Wow. Okay.
So last year it was in the canal. There's a canal. So the tumor comes out the brainstem.
Yeah.
And there's a little space between the brainstem and the bone. And then there's an auditory canal. There's this bone that kind of supports the brain. And the nerve, this little thread of a nerve goes through that canal into the ear.
Yeah.
So last year she had a 7 millimeter enhancement in that nerve in the canal. And this year the tumor is growing completely out of the canal, like an ice cream, like a blob of ice cream on an ice cream cone.
Okay.
Because usually the tumor can't grow against the bone, so it grows out.
Right.
Least resistance, as her husband said. So I've treated many patients. We have the largest experience in the world using fractionated radiosurgery for acoustic neuromas. And I've never seen one grow 10 millimeters a year. It's really a huge growth rate. And so she decided that, she remembered our conversation from a year ago and what we offered, and that most likely our success rate is 97%. That means we can stop or shrink acoustic neuroma without cutting or bleeding.
An excellent success rate.
It is very good. And we also divide up the dose. So we do things that other treatments, radiation treatments like Gamma Knife, don't do. Gamma Knife gives one treatment.
Right.
And so usually we have excellent results, and usually the people are happy. It's never 100% because I can't make 100% of everybody happy, but we're by far 97% is a pretty good number. So she's starting the treatment this week with fractionated radiosurgery for acoustic neuroma. And interestingly enough, I got 2 calls from other patients with acoustic neuroma, one from Italy that had Gamma Knife, which is a machine to give one radiation treatment to the tumor. It screws on in the head.
Yeah.
So there's pins that go into the skull and support a head frame. Our system is totally non-invasive because we fractionate or divide up the dose, so you can't screw in a head frame each time, or it wouldn't be practical.
Right.
So our system is non-invasive. We stopped Gamma Knife style treatment in 1993. So 20 years ago, we stopped. To give you an idea where I am in this scheme of things, I've been there quite a while, and doctors have known that if you divide up the dose of radiation, it's much safer. Healthy tissues around the tumor can repair radiation effects. This woman from Italy called because it didn't work. The tumor is growing now, and she wants to know what we can do about it and try to help her.
Must be terrifying for her.
It is terrifying. And another patient called who had CyberKnife. And again, we've talked about new machines aren't always better machines, right? And we showed in studies that almost half the time the new machine is less good than the existing machine. Well, a lot of people are attracted to new names and new, the word new, N-E-W, new. And this patient wrote me and called me and has trigeminal neuralgia. You know what that is?
Very, very, very painful.
Yeah, so there's off the brainstem, there's 3 nerves that come off pretty much at the same point. The 8th nerve for hearing, the 7th nerve which moves the face, and the 5th nerve which gives sensation to the face.
Right, and has 3 branches, which is why it's called the trigeminal.
Right, and so one of the complications of surgery or radiation is trigeminal neuralgia. Now, we essentially never see it. We nearly never see it. This is one of multiple patients who had CyberKnife who has called me with it, wondering what to do and diagnose it. And, of course, right now everyone's blaming everybody else, but it's a complication of CyberKnife. And it is very painful. It also occurs in multiple sclerosis patients, if you've seen people with multiple sclerosis. And, it's very painful facial discomfort. So there's treatment for her, but unfortunately, she had the dosing. Our approach for acoustic neuromas was to try to give the lowest biologic dose because we know that the majority of the treatments work. The problem is complications. How do you get rid of complications? Well, in radiation, you get rid of them by lowering the dose and by fractionating, dividing up the dose. And that's
Yeah.
what we've done. And that's why we have the largest experience in the world treating acoustic neuromas, and we treat most other brain tumors, glioblastomas, metastasis, meningiomas. But it's a nice lesson for people out there who may have an acoustic neuroma or friends with acoustic neuroma. At autopsies, there's only 2,000 acoustic neuromas a year diagnosed.
Oh, yeah.
So it's not very common. My son told me, who you know very well,
Yeah, I do.
the autopsy studies actually show 1% of Americans have acoustic neuromas.
Mm.
So it's pretty common.
Yeah, it is.
You know, if you think about 1%, there's 350 million Americans. So that'd be 3.5 million acoustic neuromas are walking around there, probably undiagnosed.
Yeah.
So what's the diagnosis? What are the symptoms of acoustic neuroma? How do you make the diagnosis? Do you know?
Well, I know that the symptoms are generally hearing loss, as you said. It's probably the most common, I would imagine.
Right.
And as far as diagnosis, imaging is probably the way to go.
Right. So the most common, if you have unilateral hearing, if one ear works pretty well and the other ear isn't working, something's going on there. It's not usual. So unilateral hearing loss. Sometimes you can hear in one phone on the telephone and not in the other. That's another symptom.
Yeah.
Sometimes ringing in the ears.
Yeah.
And sometimes imbalance. And as the tumor gets bigger, it presses on the trigeminal nerve, and people can get numbness in their face or in their mouth or in their teeth or in their gums. And so those are the symptoms. And the best diagnosis is an MRI, which is a non-radiation test. So if you get it, there's no radiation, with contrast, with a shot of gadolinium, which is contrast. It's not iodine, so you most likely won't get a reaction to it. And you'll have an answer in 60 minutes. Do you have the acoustic neuroma or not? So it's important to know that, because if you get diagnosed when it's smaller and your hearing's pretty good, you'll probably maintain your hearing. In our patients, 80% of our patients maintain their hearing, which is different than surgery, with almost every patient is deaf.
Yeah.
And having stereo hearing is important, because if you're walking down the street and someone honks at you, if you've got stereo hearing, you know why they're honking at you, and you can get out of the way and not get run over by a truck, especially if you're in New York City. And if you don't have stereo hearing, your quality of life goes down a lot.
Definitely.
So I urge people, if you have symptoms like we talked about, hearing loss, especially just in one ear, or if you've been diagnosed with acoustic neuroma, I'm happy to speak to you and talk to you about all the options. And I'd love to speak about the options. Just a few reminders. Next Sunday night at 9 p.m., we have a special guest, Dr. Paul Offit. He's the author of Do You Believe in Magic? And he's going to talk about vaccines. He's going to talk about vitamins. He's going to talk about antioxidants. He's going to talk about Dr. Oz. He's going to talk about a lot of things that we spend billions of dollars on that have no scientific basis.
And he's a brilliant, brilliant physician.
You've heard him lecture, right?
Yeah, I saw him present at Grand Rounds at NYU.
Mm-hmm. And what was the reception at Grand Rounds for him?
It was packed. I stood the whole time in the back. And I'll say that usually I'm asleep at some of those things, but I stayed awake and very engaged throughout this entire lecture. And I read his piece in the New York Times not long ago.
I hope that our listeners tune in next Sunday night, 9 p.m. We also have a show tonight at 9 p.m. on WR, and we have a show on Saturday morning on ABC, 6:30 to 7. We have a couple minutes to talk about maybe one or two more cases. We had a gentleman walk in this week, and a very nice man. He was crying. He had symptoms, weakness, fatigue. He worked for the city of New York for 30 years, and he came in with these symptoms and was fired.
Oh, no. Why was he fired?
And it was really sad. Why was he fired? Because he wasn't feeling fine.
Yeah, I can't operate when you're
So the problem was he got fired before he went to the doctor. And afterwards he went to the doctor, and he was found to have a huge kidney cancer on the right kidney. It grew, and it grew like kidney cancers grow. They went to the artery and the vein of the kidney. It went to the main blood vessel from the heart called the aorta.
Sure.
It went to the main blood vessel that goes to the heart called the inferior vena cava, and it went to the renal artery on the other side. So it's not a surgical case. There are some chemos like Sutent that's used for this disease. We've talked about Sutent in the past. We'll talk about it again. But Sutent has a response rate of about 30-40%, and the average response duration is about 6 months. And he also had some fluid on the lung. He had a pleural fluid.
Pleural effusion, yeah.
Yeah. So it may be cancerous, and we're getting him staged up with a PET scan. And we are probably going to talk to him about Sutent. We're probably going to talk to him about radiosurgery. Kidney cancer is one of those cancers that was always thought to be resistant to radiation. I mean, historically, kidney cancer, sarcoma, melanoma was thought to be resistant. Actually, they have the highest success rate. The success rate is over 90% for kidney cancer, melanoma, sarcoma.
Wow.
So even if you're told your cancer won't respond, you might want to give us a call. During the week, our number is 212-CHOICES, 212-CHOICES, which is 212-246-4237, 212-246-4237. We have a free booklet and DVD about our work. We're almost done for this hour, so we apologize that the time went so fast. We'll have another hour to take your call tonight and to talk to you about more information. Rob, it's been great to have you on the show. I know we're looking forward to Dr. Offutt next Sunday night, and we have 3 shows a weekend, and we hope you tune in.
Great. It's been a pleasure. Thank you, Dr. Lederman.
All right. Thank you, and to our listeners, God bless you. Thank you.
Thanks for tuning in to the Radiosurgery Hour with Dr. Gil Lederman and myself. If you have questions before next week's show or want a free informative booklet and DVD, just contact Dr. Lederman at 212-CHOICES. That's 212-246-4237. That's 212-246-4237. Till next week.
The proceeding was a paid program. WOR's airing of this program constitutes neither an endorsement of the products offered or the ideas expressed.